Ladies and gentlemen, sorry, my video was closed. I would like to thank all of you for being with us today at that webinar, which is sponsored by Abbott. I thank you very much for Abbott for their generous support. And it's a webinar dedicated to special patient groups and the most suitable treatment choices, something very important in our daily practice. And we have two speakers today, Professor Tommaso Simoncini from University of Pisa and Professor Natalia Pedachenko from University of Kiev. And I will introduce now Professor Simoncini and later on Professor Pedachenko. Professor Simoncini will speak about who are these special patient groups. Professor Simoncini Tommaso is full professor of obstetrics and gynecology at the Department of Clinical and Experimental Medicine of the University of Pisa and head of the OBGYN division. Tommaso is past president of the European Menopause and Andropause Society, executive secretary of the International Society of Gynecological Endocrinology, and executive secretary of the European Society of Gynecology. He is a board member and past executive secretary of the International Menopause Society and fellow at the UNDEM of the International Academy of Human Reproduction. And also, he has been elected as a foreign member of the Académie Royale de Médecine de Belgique. Tommaso, you have the microphone, you can share your slide, and at the end of his presentation, I will introduce Professor Natalia Pedachenko. I invite all our followers to write and to send me their question, because at the end of both presentations, we will have the question and answer session. Thank you very much.
Thank you very much, Professor Genazzani, for the great and very flattering introduction. Thank you, Natalia, for sharing with me this webinar, which I'm very glad to start. Let me start by sharing my slides. So I hope they are visible to you. And the topic is to discuss abnormal uterine bleeding in special groups of patients, which is a very interesting and under-investigated issue. So let's start by saying that menstrual bleeding disorders are not something trivial. They're something very important. They're a major health concern because we know there's a very important impairment of quality of life, but also on health because of loss of blood and of iron. The prevalence worldwide is estimated to be up to 30% of reproductive age women. So 1 out of 3 women during the reproductive ages have menstrual bleeding disorders. And actually, what is most important, half of them do not seek medical care. So there's really a vast amount of women who would need medical care and would need to be expertly treated. So it's a very important topic. These are the some of the data that are available on the prevalence worldwide in different countries. So it looks like different studies show different numbers. For instance, in Mexico, there's a study showing that menstrual bleeding disorders, including amenorrhea, are relevant in up to only 5% of women. But for instance, in Saudi Arabia, 65% of women in this study of more than 400 women actually qualified for having heavy menstrual bleeding. And even if not such a high number, but similar numbers like in Brazil, 35%, in Russia, 32%. So that number of 1 out of 3 patients having menstrual bleeding disorders looks very, very realistic worldwide. And what is most interesting is that we tend to look at the guidelines, the international guidelines, and to look onto scientific societies for guide us into what's the best available treatment for different diseases. In medicine, we do it in every specialty, in every field of medicine. But there's very big differences in drug availability and in the ways that the healthcare systems address diseases. And in conditions like menstrual bleeding disorders, this is even much more important than for conditions that are more of general interest, like diabetes, cardiovascular disease, neurological disorders, oncological diseases. So even the availability of drugs differs a lot in these different parts, in all the different parts of the world, which is a big issue. So let me take the liberty to start from a little bit of introduction for the sake of kind of getting in synchrony with the audience on what we are talking about. So abnormal uterine bleeding, by definition, is the presence of irregularities in the menstrual cycle, which involves frequency, regularity, duration, volume of flow, of course, outside of pregnancy. It can be acute, it can be chronic, which is most frequently what we are interested in, because if when it's chronic, so it lasts over time, it becomes a problem. We have been studying with older terms like oligomenorrhea, menorrhagia, dysfunctional uterine bleeding. We now have different ways to express in a more reliable and communicable way what's the relevant, what's the irregularity. And for instance, FIGO, the International Federation of Societies in OBGYN, has developed different ways to express this. And now we talk about normal and abnormal uterine bleeding by identifying parameters like frequency, duration, regularity, and flow, by saying absent, infrequent, frequent, prolonged, irregular, light or heavy bleeding. Plus, we have categories which are very important, like intermenstrual bleeding, which was not specifically defined in the previous nomenclature or medical terms we had been using, and also terms like unscheduled bleeding that should be used when we describe bleedings in women receiving hormonal therapies. So, which like a combined hormonal contraceptive, which is expected to provide a scheduled bleeding in the days of the absence of the intake of the pill. And if you bleed outside that schedule, then you have an unscheduled bleeding, which is also a very important category. There's another way that FIGO has tried to use to express or to categorize abnormal uterine bleeding, which is the palm coin categorization, which basically differentiates two different big categories. Categories defined by structural diseases, structural problem, polyps, adenomyosis, leiomyomas, or tumors, and categories where there's no structural disease, like you have a coagulopathy, so your blood doesn't coagulate efficiently, ovulatory dysfunction, endometrial diseases in the absence of polyps or tumors, or iatrogenic, like when we use drugs. Now, more recently, the category of AUB due to ovulatory dysfunction has become a matter of interest. Why is that? Because it's probably the most relevant reason why women bleed in an unscheduled way, in an abnormal way. This highlights those bleedings which happen because something in the ordered sequence of a hormonal production that depend on the scheduled recruitment of follicles, maturation of follicles, ovulation, and formation of a corpus luteum, which is the mainstay, the reason why women bleed regularly every more or less a month throughout their reproductive ages. Now, the AUBO or AUB for ovulatory dysfunction include basically all those conditions where there's something in this chain of events that doesn't work appropriately, thus leading to an irregularly bleeding endometrium because it's not too stable, is too thick, is not appropriately differentiated because of progesterone, and so. Now, AUBO, so I will refer to this category of problems throughout my presentation. I'm not going to talk about tumors or polyps or myomas. This is another types of problem. So AUBO during life is always a diagnosis of exclusion. So in order to be sure that it's something that doesn't really is functional, if you want, you have to exclude other problems, of course, particularly tumors. But we also understand that in some periods of a woman's life, particularly the extremes of the reproductive life, during puberty and during perimenopause, this is really extremely common. And we need to understand this, particularly in perimenopausal women. Why do I say that? Because in this age range, other conditions like the presence of a myoma becomes so frequent that sometimes for clinicians it becomes hard to differentiate whether an abnormal uterine bleeding is due to something that is to be attributed to hormonal dysfunction, ovulatory dysfunction, or to the presence of a myoma. But even in puberty, when of course anatomy is perfect in a young woman, the mechanisms that drive ovulation tend to be more irregular. So need some time in order to regularize. And this is very commonly a reason why in these age ranges, there's a concentration of abnormal uterine bleeding, which we need to understand in order to be able to have the right management strategy. Now, Natalia will address better the issue of managing AUBO. But just to give some general principles in order to pave the way to her presentation later, of course, the principles are many. So we have to choose between different types of treatments, which also depend on the patient's reproductive desires. So wanting or not wanting a pregnancy, of course, opens or closes different types of strategies, particularly the use of a contraceptive strategy. Safety is very important. Letting an ovulatory dysfunction, for instance, with low progesterone production, happen repeatedly over time may pave the way to endometrial hyperplasia malignancy. So it's something that we don't need to discard in terms of, so even having an ovulatory dysfunction has potential medical risks. But also the type of treatment that we choose depends on what we want to manage. Very often, the bleeding is not the only problem that a woman has when she has an ovulatory dysfunction. She might have, for instance, symptoms depending on high androgen levels, for instance, in the presence of PCOS. And therefore, the treatment we choose might be tailored in order to address more broadly the problems that the person has. And of course, there's many treatment options which we need to understand in terms of choosing the best one and tailoring the treatment on the patient. So now I believe that all of you who are listening here are probably thinking, okay, this is very simple. This is what we do every day. But if you think about it, if you look at the guidelines or into societies, even into FIGO documents, there's no consensus on what is best to be used in the presence of abnormal uterine bleeding due to ovulatory dysfunction. There's no guide on to whether one should use a combination of estrogen and progestins as compared to a progestin alone, whether there's a better molecule. Is there a better estrogen to address an AUBO? Or is there a better progestin over other progestins? Nobody's ever addressed in form of a consensus. So we have no guidance. And as I said before, in some countries, you don't even have the choice of that many products as you might have in other countries. So in some ways, you use what you have rather than what you would like to use. Then again, how long should you treat? Of course, it depends on the age of the patient, on their reproductive desire, but there's no rule and no guidance on how to do an optimal sequencing. Should I start with this concept? And if it doesn't work, should I transfer to another treatment concept. Nobody says whether there's which is the best sequence, which is very funny because, as we have said, this is really the meat of our clinical practice as gynecologists in our outpatient services. This is what the patients more frequently look into our experience. So the classification system introduced recently last year by FIGO on ovulatory disorders, if you look into that, is a categorization that describes the relevance of the problem by saying, by associating the problem onto how occasionally or how frequently one patient does ovulate or does not ovulate, on the presence of evidence of infertility associated to the ovulation, which is also a problem, and on the type of main reason for insufficient or inconstant ovulation. Is it a hypothalamic problem? Is it a pituitary problem? This is more near to our way to study. When we teach in the university the cycle disturbances, we tend to, I think, everywhere in the world to describe, to explain to students where is the main problem. Is it the hypothalamus? Is it in the pituitary, in the ovary? Do you have PCOS? And of course, it's over. It's anyway an ovarian issue, but of a different type. So FIGO does a very good work into categorizing the relevance, the frequency, and type of problem providing the ovulatory dysfunction, but it does not address which is the most appropriate, the best management strategy in the presence of one of these conditions compared to other types of approaches. And it doesn't address even the problem of the disparities in treatment practices in different regions of the world based on cultural issues or availability of drugs. So the other issue that we said before is the misperception of AUBO based on women. So I think we all encounter and we have learned by doing our job in our clinical practice how broad is the variation in the awareness of abnormality. So there's women with very light and regular cycles that come and complain because they've had their cycle 2 days before this month than usual, because I'm generally a Swiss clock. This is how they describe their regularity in Italy, at least. I am a Swiss clock. So every day, every month, I expect my menstrual cycle every 28 days. And this time I had a cycle 2 days before. Is there something wrong with me? On the other side, we have patients that have extremely heavy cycles, maybe having to use 10, 15 pads every day. They have to use 3 pads during night. And they say, oh, I have an abundant cycle, but it's always been like that. And they think it's normal. They perceive it's normal. So this is, of course, broadly variable based on different sides of the world, and this has not been investigated too much. And of course, many patients have also avoided seeking, even when they recognize they have a problem, they don't seek a treatment because they have the fear of the side effects. Particularly young women, they live with the fear of the side effects of hormonal contraceptives with a lot of misperceptions, like if I will use a hormonal treatment, I will gain weight. This is the most frequent. But also some people, maybe in the later reproductive ages, they think they will get cancer. They think it's dangerous in general. They will get a myocardial infarction. This is not that infrequent. And of course, differences in access to healthcare. So not in every country it's easy for a patient with an heavy menstrual bleeding due to ovulatory dysfunction to find a physician who's expert. So my task today is also to discuss the difficult patients, the difficult groups. So we do understand that sometimes it's easy. Sometimes you have a patient, she doesn't seek pregnancy. She just has maybe heavier bleedings, more pain during her menstrual cycle than before. She wants an hormonal contraceptive and she's fine. This is the easy patient. You may not even have to strain that much into tailoring the treatment because probably in these cases, any hormonal contraceptive would be fine for her. But there's different groups where things might be more difficult. For instance, and here are examples: adolescents, teenagers, women with immature ovarian axis or transitioning towards puberty, women with contraindications for certain drugs, for instance, contraindications for the use of estrogens, and we will look into that. Women who seek pregnancy are very difficult because you have a patient with an abnormal uterine bleeding, with an ovulatory dysfunction, and she's seeking pregnancy. So you can't use things that prevent pregnancy, like contraceptives. There's very little to make ovulation more regular. There's something, but there's not that broad amount of concepts that we have available. And the later reproductive age is a challenging period of time. So just to give some very brief concepts, the younger patients, some of the most difficult abnormal uterine bleeding that I have personally had to manage, and I think it's the same experience with all of you. It's in adolescent patients. After the first menstrual cycles, in some, luckily enough, not in all, but in some young women, you have very regular, very heavy bleeding, sometimes continuous bleeding, and it's very hard to address this bleeding. Not just because sometimes they don't respond as you would expect with the elder individuals to an hormonal contraceptive, progestin, but very often also because we have evidence that using hormonal contraceptives in these younger ages might actually lead to side effects. One of the most known is the use of ethinyl estradiol containing combined hormonal contraceptives. And why is that? Because ethinyl estradiol is a very powerful suppressor of the synthesis of androgens in the ovaries and a very powerful inducer of SHBG. And this is thought to have an effect on the bone formation of these very young women. So there's some concern that has never been demonstrated to be something that serious like in a lifetime fashion, but there's some concern that, for instance, some contraceptives might need to be used carefully in very young women. And those contraceptives which are not containing ethinyl estradiol are very often less effective into the control of abnormal uterine bleeding. So this is a difficult group. Another difficult group, as I hinted to before, is women with contraindication to estrogens. And of course, here it's always a risk benefit balance that we need to put together. Why is that? Because of course, when you have a woman with a contraindication to estrogens, and you are considering using an estrogen in a combined hormonal contraceptive or in a replacement therapy, it's because you have a reason to consider this balance of risk. And of course, the most frequent reasons that induce a risk is liver dysfunction, liver disease, cholesterol, high cholesterol levels, high blood pressure, the risk of developing a deep vein embolic event. But on the other side, you might have women with severe hyperandrogenic issues. You have to protect them from heavy menstrual bleeding. So, discussion with women and trying to identify the best combination that minimizes the risk and maximizes the benefit is the real medical counseling, is where we need to have an expertise onto the clinical conditions they have and onto the different concepts we have. And again, here we can play a lot with combinations of combined hormonal contraceptives with ethinylestradiol, with natural estradiol, with estratrol, with different progestins. We can also play by using a progestin alone or an IUD and adding estrogens in different ways like transdermal. But again, do you have a guide around that help you choosing? There's no guide. There's some indications where you should be more careful into using 18-estradiol, particularly containing hormonal contraceptives or estrogen-containing contraceptives, but there's no formal guide on how you should reason into building up your counseling. And of course, there's women who are really in trouble in using particularly estrogens. For instance, those women who have had an endocrine sensitive tumor. And very often in the reproductive ages, women who use, in some countries, for instance, women are provided with tamoxifen before menopause without adding a GnRH analog, which is, of course, something that helps a lot in controlling their bleeding. And these women tend to bleed a lot, and it's a problem in addressing their problem. And of course, again, I mentioned this before, women who seek pregnancy, here there's a real lack of guidance onto how to approach those who seek pregnancy. Which is the best strategy? You should use a progesterone, you should use a progestin. There's some progestins that suppress ovulation, others that don't suppress ovulation. So which is the best to be used? Which is the best dose? When you should stop taking drugs in order to allow for ovulation? This is difficult. And just to conclude my overview of conditions is the perimenopausal period. Here it's very challenging because in these women you don't have only menstrual irregularities, but you have very often climacteric symptoms. So the strategy that you have to use needs to take into account the fact that these are elder women. More frequently, they have conditions that make it more likely to have a DVT event. Maybe they're overweight, they are hypertensive, they have high cholesterol levels, because it's more frequent to have these conditions at 48 years of age rather than at 28. And of course, you need to address their need for symptoms. So here you have different types of solutions. You use a formal, normal oral contraceptive. You may use HRT, but then you're not suppressing ovulation, and therefore cycle control might be difficult. You can use a progestin only. You can use estrogen only in some cases. You can use IUDs. And again, no guidance, formal guidance onto which is the best and more rational strategy. So to conclude, ovulatory disorders are a common cause of abnormal uterine bleeding in women of reproductive age, but actual guidelines lack of clear management recommendations. So this is something that we need to think about as ISG. I would urge Professor Genazzani to promote that a society like our society in some ways becomes leader into trying to start a consensus, which would be very complex. Now, current guidelines do not address the unique clinical challenges in certain patient groups. So it's not in general, but it's in these specific patient groups that I mentioned during my presentation that we particularly need guidance. And a simplified decision point hierarchy will be extremely useful to direct therapeutic choices. And then looking at the broader field, we would also need guidelines that are usable in different parts of the world. Because as I said, the cultural environment, how women feel about their cycle is not the same in Europe, in Asia, in Africa, in the different parts of the world. And the drugs that we have available, the hormones that we have available are very different. So we need to take that into account in an effort to try and accomplish as best as we can the needs of women everywhere in the world. So thank you for listening to me. And of course, after Professor Pedachenko's chat, we will be very glad to address any question you have.
Thank you, Tommaso, for that beautiful lecture, which is not only give a picture, a general picture, but it really offer what are the characteristics of the patient at the various ages and according to their possible needs. And then now we will have Professor Natalia Pedachenko. Natalia is full professor, head of obstetrics and gynecology and perinatology department at the Shupik National Healthcare University of Ukraine. Is member of the working group of the Ministry of Health of Ukraine for the development of national clinical gynecological guidelines approved by the Ministry of Health of Ukraine. She's executive secretary of the Society of Gynecologists and Endocrinologists of Ukraine. I went many times to your beautiful event in Kiev, I still remember, and she's also coordinator of the educational branch of the Association of Colposcopy and Cervical Pathology. And today, Natalia, she will speak about selection criteria for the most suitable treatment choices. Thank you very much. We have the microphone. Please, you can start with your presentation.
Dearest Professor Genazzani, dear Andrea, I'm very grateful to you, to the ISG Society, for the honor of this kind invitation to talk today about this really important topic. And I'm extremely grateful to Tommaso Simoncini, the professor from Pisa University, who so deeply described the problem. And of course, after such important webinars, we will try to find a solution for these treatment choices. And what can we do now is trying to discuss, and maybe later we will have some papers and maybe some guidelines on this topic. So, talking about this problem now, it is very important to understand that even 3rd century before Christ, the father of medicine, Hippocrates, wrote his famous corpus, and 3rd century before Christ, he described 4 determinants of gynecological disease. And every one of us has to understand the importance of this paper and has to understand that we are not something new on this topic now. We didn't achieve extremely new information now. So the menstrual dysfunction, the Hippocrates told, is the cause of gynecological disease. So it is very important to treat abnormal bleedings, one of the variation of menstrual dysfunction, in order to prevent more deep, more severe gynecological diseases. Pregnancy is a possible cure, isn't it, dear colleagues? It could also be accompanied by pain, which we know from hundreds of our patients. And if the woman is left untreated, this problem with menstrual dysfunction, with bleedings, may lead to infertility. Isn't it actual now in our world? Yes, in 21st century. Talking and continuing to talk about the epidemiology of the problem, I would like to show you there's some statistics in our country. We don't have rather fresh statistics because of war in our country. But if we will see to the Center of Medical Statistics of the Ministry of Health of Ukraine in 2013, we can see that 11 per 1,000 women of reproductive age and almost 29 per 1,000 girls, 15, 17 years of age, had been firstly diagnosed the menstrual cycle disorders. So the percentage is rather high. And it is increasing. The frequency of these disturbances is increasing. If to see from 2008 till 2013, it had been already increased by 4.5%. We know from the guideline of FIGO in 2018 that about 1 to 2% of women with improperly managed anovulatory bleedings eventually may develop the endometrial cancer. So this problem cannot be underestimated by physicians. And the quality of life is, of course, greatly and deeply impaired by these abnormal bleedings. And of course, it has a huge economic burden on society, on national healthcare systems worldwide. Afterwards, I would like to talk about the regulatory framework in Ukraine. We have a unified clinical guideline, which is called abnormal uterine bleedings. It was established in 2016, and it currently allows, it is a working active guideline for our country, and it allows to detect and treat abnormal uterine bleedings, and of course meets the modern international guidelines. It was written in 2016, so afterwards, we had some printed and published scientific resolutions, which include the renovations. Yes, for example, FIGO 2018 renovation, but this guideline is rather nicely and clearly written and is very popular in our country. What is important for me to share with you in our this existing and actively working guideline, that we have 4 questions which family doctors and gynecologists of our country can tell even if you wake up them at night. And these questions are extremely important during the primary consultation of the patients. And if one of the answer is positive, of course, if 2 and more, it is almost definite that the patient has abnormal uterine bleeding. First question, does the menstruation affect daily activities? Do you have to change hygienic products at night? Are there large blood clots, more than 1 centimeter in the discharge? And do you have any symptoms of anemia? Yes, short of breath, feeling weakness, tired, or already you have the diagnosis of anemia. So these 4 questions are known by Ukrainian gynecologists and family doctors, as I had mentioned also, and our Society of Gynecological Endocrinology, with the president of Professor Tatiana Tatarchuk, had made also very important step. These 4 questions are also present in the Unified Clinical Protocol of Primary and Secondary Medical Care of Iron Deficiency Anemia. So even hematologists and therapists know that abnormal uterine bleedings is an important problem, and it can also, as other reasons, can cause anemia in patients. And the problem of anemia is really so important. We have the statistics, for example, that more than 50% of women who need inpatient care, according to their depressive state disorders, the only one reason of this depression is severe anemia. And after the treatment, they become again normal, healthy people who can have high quality of life. So we have to individualize the our strategy, because what is individualization? It is a differentiated approach for choosing of method of treatment, taking into account the age of the woman, the state of her physical, mental health, needs in this moment of time, and other important factors that can really affect the recovery. So the modern medicine needs this individualization, and it is also the concern which Professor Simoncini was talking about today. We have a lot of unsatisfied management needs for treatment of abnormal uterine bleeding due to dysovulative disorders. We have class differences in really drug safety profiles. We have to differentiate recommendations of certain group of patients, as was already mentioned today. There is no existing guideline for sequential treatment of some plants, which type of treatment can follow another one according to different needs of a patient in this exact period of time. And different types of bleeding need different treatment approach, and so on, including the unified guidelines and which could be common to all over the world, yet all the countries. What is really interesting, after the FIGO 2018 guideline concerning abnormal uterine bleeding, then in NICE 2021 guideline, we already see that something new appeared, that in the place of hormonal therapy of AUB, we can use progestogen in a cyclic mode, not prolonged, but in cyclic mode. And this is very important achievement of evidence-based medicine, which had to be, of course, taken into account. And in our country, when we will reconsider our clinical guideline, and of course, maybe in further publications concerning the individualization of treatment and the selection criteria for these treatments. Talking about the progestogens, especially in cyclic mode, it is very important to see the dydrogesterone, because this molecule is really amazing and unique, because first of all, it does not block ovulation at a therapeutic dose. There is no any estrogenic effect and no any androgenic effect, and it is provenly metabolically neutral. There is an absence of corticosteroid effect. And this makes this really terrific molecule be unified and be universal for lots of groups of patients. First of all, dydrogesterone preserves the positive effect of estrogen on metabolism and proteins. Yeah, it is very important for us. It preserves the positive effect of androgens. And it is extremely also important in adolescence and in perimenopause, when we need the proper bone mass density. Then, progesterone is not contraindicated in women with risk of thrombosis, with cardiovascular risks. It is not contraindicated in diabetes patients because it does not interfere with glucose metabolism. It does not depend on food intake and does not somehow influence badly the gut microbiota. Is also very important. It does not affect the bioavailability and metabolism of other drugs which can be taken by patients. Photosensitivity is absent, so patients can easily use dydrogesterone under the sunlight, and they will not have these dark spots on their faces, which impressively decreases the compliance. And it is not contraindicated with migraines and epilepsy. So, rather unique possibility for us. Also, dear colleagues, I'm very happy to share with you that around 1 month ago, in October 2023, in Ukraine, we had a second already forum of experts concerning the problem of abnormal uterine bleedings. 12 leading national experts in the field, especially of endocrine gynecology, took part in this meeting, and the main goal was to summarize all the data which is not considered in the current protocol, which I have shown to you already, including updated international recommendations and key studies on this topic, and to develop, basing on this new knowledge, an algorithm for the treatment of abnormal uterine bleedings, considering an individual approach, selection criteria to each patient. And of course, following the results of the forum, it is planned, we are working on this field now also, to publish a resolution which will reflect really in detail the agreed position of Ukrainian experts on the management of patients with abnormal uterine bleedings. And what was the idea? To make it easy to understand, to visualize for each doctor, and what we have established already, I'm trying to share it with you before it is published. First of all, as Professor Simoncini mentioned, we have to make a proper classification of abnormal uterine bleeding. We use the classification of FIGO, palm coin mnemonic, we know, and if we have structural, anatomic causes, okay, we go to the proper protocol. If we have functional causes, then we go to FIGO 2022 with other mnemonic hypo-P, yeah, gain fit pi, another one, to deeply understand the reason of each level of probable disturbance. And then we try to categorize these patients, for example, by age. If we are talking about the adolescents, first of all, maybe it is important to understand that there is a non-hormonal treatment, of course. We can use NSAIDs and tranexamic acid for abnormal uterine bleedings due to ovulatory cause, dysovulation. Yeah. If we do not achieve any success, we can follow to hormonal treatment. And in adolescence, as well as in a later period of time, the first question will be if the girl needs contraception. If the answer is yes, the first line of treatment of AUBO should be, as it is already written in our national guideline, the combined oral contraceptive containing estradiol valerate and dienoges in dynamic dosages regimen. Because it is not only the estradiol valerate containing combined oral contraception, which will not interfere a lot with bone density, but also because in the instruction for medical use, we have a very important indication, not only contraception, but a treatment also of heavy menstrual bleeding. So we are fully in the legal field, talking about adolescents. Yeah. The second line, if the girl needs contraception, okay, it can be the levonorgestrel containing intrauterine device, but 13.5 milligram. This is off-label use for treatment, but it is okay for contraception, and we know that it will work also with bleeding. If contraception is not needed for the girl, she is virgin or she simply doesn't need it now, it can be gestogens in cyclic regimen, and here it is the best option according with the information we have already talked about. It can be dydrogesterone by in cyclic regimen from 11th to 25th days of cycle, not less than 3 cycles, best of all 6 cycles of use, because we know that have data that shows that its therapeutic effect will continue even after the stopping of the treatment, and it will perfectly work with abnormal uterine bleedings, definitely. Talking about the reproductive age, also we need to answer the question about the reproductive plans. And Tommaso also had mentioned this problem. If person needs contraception, okay, it can also be COC, First line, of course, estradiol, valerian, dienogest. Second line, other COCs, but the use of them for treatment of abnormal uterine bleeding will be, of course, off-label. And it can be progestins. First line, of course, as indicated, is levonorgestrel intrauterine device 52 milligram. Second line, if person needs contraception, okay, it can be progestin only pills, but the use for treatment will be off-label. If a patient needs to achieve pregnancy now, it will be also the example of sequential use of different types of treatment. For example, she's taken estradiol, valerian, dienogest, or other COC. When she tells us about their desire to achieve pregnancy, we can stop this COC and switch her to other hormonal treatment containing also the cyclic regimen for dydrogesterone from 11th to 25th day of cycle, and it is provenly does not affect ovulation, and it is easy to achieve pregnancy on this scheme of treatment. And of course, non-hormonal treatment take place in this group of patients, also NSAIDs and tranexamic acid. If the use of estrogens is contraindicated in this active reproductive age group of women, okay, the use of the same scheme, hormonal and non-hormonal treatment, will be the same as with women who seek pregnancy now. But if they need contraception, of course, if estrogens are contraindicated, she will use progestins, intrauterine device with levonorgestrel, or progestin-only pills, but of course with off-label use. So, talking about perimenopause women, the main question for this age is also contraception. Now women are very young for a long period of time, at the age of 43, 45 years. For some of them, they have grandchildren, some of them seek for their prince, and some of them try to become pregnant. So it's very interesting age for women. And of course, we have to ask about the contraception. If a woman needs contraception and she has abnormal uterine bleeding of ovulatory cause, okay, she can also use estradiol, valerian, dienogest in dynamic dosages regimen pills, or she can use levonorgestrel intrauterine device. If later she will experience vasomotor symptoms, we can add transdermal estrogen for her, for example. If a person does not need contraception in perimenopause, we have to base on her vasomotor symptoms. If she has a combination of bleedings and vasomotor system, okay, she also can use dydrogesterone 11th to 25th day of cycle, and maybe if she has vasomotor symptoms, we can also use dydrogesterone and add transdermal estrogen in low dose, or we can go with her with menopausal hormonal treatment protocol and try to achieve good results. She also can use levonorgestrel intrauterine device if she has vasomotor symptoms, and we can add, as I told already, the transdermal types of estrogen. So if it is not working and with poor tolerance, of course, the last of our recommendations should be the surgical treatment of abnormal uterine bleeding of ovulatory reason. Talking about history today, we have to remember that first hormonal preparation was established, created for menstrual bleedings in 1962. Maybe I'm mistaken, but around this date. Then it had become widely used for safe hormonal contraception. And now again, we are trying to make hormonal drugs being not just contraception, but we try to use them again for bleeding therapy. And it is very nice. And the history is making this nice circles. And remembering Hippocrates again, he told that diseases never affect only one part of the body. They affect the health balance of all the body. Yeah, health balance. And the best physician is one who can prevent and predict. So he is a father of popular 4P medicine as well. And we hope that we will proceed with good luck in medical science after this father of medicine. Andrea?
Thank you. Thank you. I thank you very much, Natalia, for your presentation. And then we will go now to invite also Tommaso to join us. And we will go now to the general discussion. As you know, we had a beautiful tut also on adverse uterine bleeding, difficult cases and specific cases, and what kind of treatment they can be used. But since the beginning, when Tommaso was introducing the topic, you have seen that this is something who can happen during all the female life, starting from early adolescence, from the first cycle, I think the first menorrhagia, and then ending at the end with menopause. Then we have received several questions. I invite all our participants to write their question. And then one question, she's from Ruslan Raff. Does the effect of COC on bone density depend on estrogen component and its dosage?
Start answering before Professor
Yes,
Simoncini is linking better. There are several nice investigation concerning the impact on bone mass of combined oral contraceptives. And one of the most interesting studies is Helsinki studies, which was published in Osteoporosis Journal of Medicine. And the very important result was that they estimated the level of growth hormone basing of serum level of insulin growth factor 1, because they are very similar in serum. And they saw that during the combined oral contraceptives, the higher dose, the most effect was seen, that it reduces the insulin growth factor almost around 60%. So it can influence the bone health also. If talking about estradiol taken Peros, it decreases the insulin growth factor around 20%. But transdermal use of estrogen lowers the less, around 11% of insulin growth factor. So they understood that the type of estrogen and the way of administration matters a lot. And of course, the gestogen, progestin matters. The less impact on growth hormone had levonorgestrel, and other third, fourth generation had, of course, higher effect on this bone health.
Thank you very much, Natalia. Do you think the treatment of chronic endometritis will also benefit from gestogen?
Very nice question, dear colleagues. Thank you so much. There are very interesting studies showing that, for example, the comparison of antibiotic treatment and antibiotic plus dydrogesterone treatment has much more positive effect in group of patients who took not only antibiotic but dydrogesterone molecule as well. And it is known that dydrogesterone has impressive effect on immune system metabolism, and it can also act as anti-inflammatory drug, talking about endometrium especially. And it also has much higher specificity to endometrial receptors even more than natural progesterone. So it, of course, the use of dydrogesterone will benefit with patients with chronic endometritis, of course.
Thank you. Tommaso, you can hear me, but we don't have connection from your microphone. Then I will introduce another question from Mirella Maliki. She's writing English. I will translate she writes in Spanish. I will translate in English. In adolescents with adverse uterine bleeding and a very great anemia, what should be the first treatment that you can believe you can use to try to block the hemorrhage?
Can you hear me now? Just trying to.
Yes, now we receive you. Fantastic.
Very funny thing. So I've been using my microphone up to for the presentation, but then something went off. I don't know what. So okay, I'm available for questions now.
Thank you. Then okay, you have understand the question, Natalia?
Yes. So no, yes, I'll try to take that, which is a very difficult one because of course, there's many ways one can address that. I think the best way to try and address this problem is to try and see if we can support the luteal phase with a progestin as a first starter in order not to interfere too much with estrogens. Sometimes this is sufficient. So if it's just heavy menstrual bleeding, some irregularities in bleeding, just using a progestin, we generally use the dydrogesterone, but any progestin can be used in order to support the luteal phase would be fine. If it doesn't work, then things become nastier. And of course, sometimes using a hormonal contraceptive is important in order to suppress completely ovulation. I like to try with combined hormonal contraceptives containing natural estrogens, like natural estradiol, basically, for the issue of ethylene estradiol that Natalia explained very well before. But again, sometimes you need something that controls the cycle even more. So I think it's a kind of step up approach. So a progestin, then combine hormonal contraception with natural estrogens, and then eventually you go to ethylene estradiol containing COCs, maybe starting with a lower dose, like a 20 microgram containing ethylene estradiol before going to upper dosages. Sometimes I also combined a strong progestin, trying to control the bleeding with transdermal estrogens, which of course is something we do more. We like to do a little bit more in very young patients. Also during pubertal induction, we prefer using transdermal estrogens to support the endometrium, not to have them bleeding. So these are all, I think, valid approaches.
Thank you, Tommaso. And then now for Natalia from Elena Rota, what is the best dose of dydrogesterone for adverse uterine bleeding treatment?
Oh, very nice question. Thank you, dear colleague. I will share with you our experience. How do we work? Firstly, we prescribe 10 milligrams per day for our patients. But before we let the patient go home, we explain that if she will have some blood spotting during the use of dydrogesterone, she can increase the dose by herself to 20 milligrams per day. Maybe she will need it for several days, maybe not. She will make this creativity by herself. But if she has some concern, or we have some concern before the prescription, maybe she is a little bit overweight, or she has some maybe gut problems, gut inflammatory disease and so on, irritable gut, we can prescribe her 20 milligram for the beginning. But usually we start with 10 and recommend the patient to increase the dose if she has some spotting.
Thank you. And then Tommaso, for you, from Rita Grifoni, is a liver angioma a contraindication to COC?
No, absolutely. Angiomas are not a contraindication to the use of combined hormonal contraceptives. There's no evidence that there's an increased risk of thrombosis in the angioma, and it's not one of those conditions in the liver which are suspected to be at high risk of growing during combined hormonal contraceptives. So it's okay to use them. They're so frequent that and in most cases, we don't even know that they are there. So I don't think it's very common that maybe a woman needing a combined hormonal contraceptive knows if she has or not an angioma. So no problem.
Thank you. And Natalia, now a question from Mirella Maliki, still in Spanish. I will translate. In adolescents with abundant bleeding during menstruation and anemic condition, what is your initial approach to control the bleeding in adolescents?
So much in adolescence, of course, the first line which we experience to use is tranexamic acid in proper dosages in combination with NSAIDs, for example, ibuprofen. And this treatment should be started from the first, let's say, blood spot, and it will work. If it is not working properly, of course, then we switch to hormonal treatment, but we begin with non-hormonal treatment usually.
Thank you. And then Tommaso, for you, from Efrain Lopez, still in Spanish, in a patient of 42 years, virgin, who went to emergency room for abdominal bleeding, ultrasound show normal uterus and ovaries, endometrium 7 millimeter, and the question is, can we use for this kind of patients dydrogesterone? 42 years.
Yes, no, I think in a chronic treatment, yes. In the acute treatment, probably, so the strategies that need to be different. So acutely, when you have a heavy bleeding, which is really hemorrhagic, probably the best strategy is to do a hysteroscopy and to do an endometrial ablation. This is the best way, a quicker way to stop an ongoing bleeding in the acute setting. Now, if you want to so if you would start giving dydrogesterone to her, even 20 milligrams of dydrogesterone every day, or even more, you will probably need several days in order to decrease the bleeding. So in other ways, it's probably more tranexamic acid to favor coagulation, and eventually a surgical treatment of the bleeding, like with an hysteroscopy, to treat the hemorrhage. But otherwise, yes, of course, you can use dydrogesterone for 2 weeks every month in order to prevent that happening again, which would be then easier to be accomplished.
Thank you. Then Jose Jimenez for Professor Pedachenko. It's better to use estradiol plus natural progesterone versus estradiol plus dydrogesterone in perimenopause or postmenopause. What is to be the best treatment?
A very nice question. And of course, your choice is the best. Whether you use dydrogesterone or micronized progesterone, it is both safe for breast cancer prevention or for cardiovascular prevention. It is both safe, but maybe more confident and more easy for use is the dydrogesterone molecule, because it is only 10 milligram and it is much easier to use Prof than to use intravaginal micronized progesterone for 2 weeks sequentially each month. You can use it Prof only. Also, of course, talking about the micronized progesterone, but the intestinal side effects, of course, are much less, almost absent, when talking about the use of unique dydrogesterone molecule.
Thank you very much. And then now, Tommaso, for you, from Franklin Solis, in a perimenopausic woman with an intramural myoma and adverse uterine bleeding, what is the best way to approach the patient?
Well, yeah, this is a very, very good question, and I think one of the clinical scenarios that we face every day. Here the problem is that we expect, since the woman is perimenopausal, if she has a problem with bleeding, she will, of course, be very much looking forward to becoming menopausal so that the problem goes out. I think that the best approach, and of course I'm giving for granted that it's very likely that the reason, or at least part of the reasons why she bleeds a lot, is because of the myoma, because we all know that if the myoma is subserosal, so if it's on the outer part of the uterus, then this would simply be an innocent bystander, so not something really giving the bleeding, but something being present. So even if the myoma is part of the cause of the bleeding, I would do whatever is possible to avoid a surgical procedure. And of course, I would use any strategy that allows to control bleeding better. It could be an hormonal contraceptive, which is generally also useful in these perimenopausal women to avoid an unwanted pregnancy. I would then prefer either something with natural estradiol or with estetrol, because I want to avoid ethinyl estradiol. I could also consider a progestin-only pill. An IUD, if the myoma is intramural, would be ideal. An IUD loaded with levonorgestrel would be a perfect strategy to drive the woman through menopause. And of course, if everything fails, then we also now have newer strategies, at least in some parts of the world. We have, for instance, the associations of GnRH antagonists with replacement therapy, which is something that is actually being developed exactly for these cases. And of course, if you're desperate, then there's surgery, of course. But that's the last thing we want to consider.
Thank you, Tommaso. And Natalia, for you, a question from Yair Frankel. What non-steroid anti-inflammatory drug do you prefer and how you treat?
Yeah, thank you for your question. Our preferable NSAID for the start is ibuprofen, but we have to use it from the beginning with the proper dosage in order to make it working. We start using 600 milligrams once or twice per day in adolescence and then in later reproductive ages, if talking about NSAIDs, of course.
Thank you. And Tommaso, a question from Elena Rota. Do you have any experience about embolization to treat adverse uterine bleeding caused by multiple myoma?
Yeah, it's a very effective treatment, but it's a very painful treatment. So I don't think it's something that really it should, can be used or clinicians use as a first choice. Of course, it's something that can be used. If you embolize the uterus, you will have a big reduction, a big decrease in bleeding in the acute setting, but mostly in the chronic setting. But most women require staying in the hospital. They have significant lower quadrant pain for several days. So I think there's better ways to do, like an operative hysteroscopy with endometrial ablation is probably something quicker and equally effective with less pain.
And then Natalia, for you, from Abraham Devora Martinez, what would be your recommendation in patients in the first 2 years? Sorry. Some water. Of menarche, in the first 2 years of menarche with heavy bleeding and thrombogenic heart disease.
Mm-hmm. If we have heavy bleedings in adolescence, of course, we have to treat it firstly with NSAIDs, and then we can switch to hormonal treatment. But if we have contraindications for estrogen use, for example, with thrombogenic heart disease. Of course, our best choice will be progestins in cyclic regimen, and we have to individualize the dosage, the daily dosage regimen for the patient. If it works with 10 milligram from 11th to 25th cycle days, it's okay. If it doesn't work, let's switch her to 20 milligram.
Thank you. And then,
Yes, and it will also help to establish the normal development of hypothalamus pituitary ovarian axis. It doesn't suppress these cyclic processes.
then Tommaso, Wilson Granados Reyes asked, what is the best treatment for a 42-year-old woman with adenomyosis, endometrioma, and abundant abnormal uterine bleeding?
Well, I think that the best treatment is the best treatment for endometriosis, which right now is a progestin only. The progestin that we have more data, or at least we have an indication for the treatment of endometriosis, is Dianogest. We have several forms of Dianogest now. We have Dianogest alone. We have Dianogest associated with some estrogens in cases women do bleed irregularly. So I will go first with the Dianogest treatment in case it's not feasible. Other progestins like levonorgestrel have been also being used for the treatment of endometriosis with success. There's a lot of data. It's also possible to use a progestin-loaded IUD. So an IUD loaded with levonorgestrel has also data on control of bleeding and on menstrual pain in women with adenomyosis. Some might worry that it could be less effective on the ovarian endometriosis, which is possible. Therefore, I would prefer a general systemic progestin. But there's also some data that suggests that it's also effective near the uterus.
Thank you. And then now a question, Natalia, from Guillermo Augusto Rojas Avellaneda. What should be the treatment for an adverse uterine bleeding in a patient with a breast cancer?
A very difficult patient group, of course. With breast cancer in the history, treated breast cancer, yeah?
Yes.
Because usually they take treatment which suppresses ovulation and suppresses any cyclic processes, and they are amenorrheic. Or if they take Fariston or some other anti-estrogenic drugs for neoadjuvant therapy after the breast cancer surgery. But if it happens after the cessation of this anti-estrogenic neoadjuvant treatment, of course, we can use NSAIDs and gonadotropin hormone, the agonist of gonadotropin releasing hormone injections, or antagonists of gonadotropin releasing hormone in tubs. So what is available on your pharmaceutical market, but never we can use steroid hormone preparations for the breast cancer survivors.
Thank you. And then, Tommaso, a question for you. What about women with high risk for deep vein thrombosis?
Yeah, women with high risk for deep vein thrombosis should avoid systemic estrogens. So if a woman has an abnormal uterine bleeding, you can use a progestin-loaded IUD easily. You can use a systemic progestin because there's no increased risk of thrombosis. And in case with any of the two strategies, women bleed irregularly because of too much atrophic modifications of the endometrium, I think it's feasible, and I personally do it clinically, to add some transdermal estrogens, exactly like we do in after menopause, because we know that transdermal estrogen, estradiol, of course, does not induce a first pass liver effect. Therefore, there's no additional increased risk of DVT. So these are the best possibilities we have.
Okay, then we have Natalia Femina, who make you compliments to Natalia, to you. And then she asked, what are the tactics for perimenopausal women with AUB when endometrial disease is suspected, while we are waiting for the histology results? And non-hormonal therapy is ineffective, and the woman is categorically against surgery in the future. Levonorgestrel system as an option?
Of course, of course, you have already given the answer. Usually in our clinical practice, after making hysteroscopy and taking the endometrium for morphohistological investigation, we wait until the results, 7 days, 10 days it is usually needed in our country. And then we decide which type of treatment for prevention of these bleedings we should choose. But if you have the prolonged period of this histological answer, of course, you can use the intrauterine device containing levonorgestrel absolutely safely. Absolutely safely, because it can be also used for treatment patients even with atypical types of endometrial hyperplasia.
Then, Natalia, I would like to ask you if you go in question and answer, because we have a question written, I don't know if it is Ukrainian or Russian. And then it's the question is just the question above Natalia Femina, done by Larissa, and then I don't understand, I'm sorry. Can you read the
Where
question?
I can see it,
No,
Andrea.
you will read the question and you will raise the question to Tommaso, because just we will see.
So I have to find this question. Non-steroidal anti-inflammatory drugs, they influence the enzymes, they interfere with normal follicular growth and interfere with cycle disturbances. How do you manage with this situation? Very good question. Is it a question for me or a question for Simoncini?
If you want to answer, you can answer.
So I can answer in a very practical way. So we can speculate about molecular actions, biochemical actions, whatever we want. But sometimes when we need to use drugs, in this case, in the setting of abnormal uterine bleeding, of ovulatory dysfunction, we need to use these drugs because there's a need from the patient, a clinical need. So these types of treatments, of course, are useful, particularly to address pain with prolonged cycles, painful cycles. So while I understand all the issues of the potential interferences with ovulatory mechanisms, and therefore it might seem unlogical to add something that interferes with ovulation in a patient that has already ovulatory problems. However, we're not going to use these drugs for the whole month. We would probably be using them for 1 or 2 days when the woman has more prostacyclin and prostaglandin released from the uterus in order to address that problem. So I think it's more of a theoretical question than something that is really relevant in the clinical practice. So I think if you need to use them, it's perfectly okay to use them even in patients that have ovulatory dysfunction.
Okay. Do you want to add something, Natalia, to that question, to that answer?
No, there's really nothing to add, because really we know that the action of NSAIDs is rather strongly interfered and connected with ovulatory function. But of course, we should not use them in the middle of the cycle, especially in women who seek pregnancy. If we use them during the menstruation, and better 1-2 days before, to prevent pain and to make the bleeding less, why not? It will not interfere with, it will not influence the cycle.
Thank you. And then we have a question for you. A 17-year virgin girl with heavy menstrual bleeding and bronchial asthma, acne, and low hemoglobin. What is the treatment choice?
In adolescence, we have, the bronchial asthma is strongly dependent on estrogen fluctuations. And even patients who are treated by switching off the menstrual cycle, they impressively lower the bronchial asthma attacks. So the best option for both of these diseases, the somatic bronchial asthma and abnormal uterine bleeding due to ovulatory cause, will be, for example, combined oral contraceptive with the minimum hormonal-free interval. For example, it can be also levonorgestrel dienogest. It has 26 active tabs and only 2 hormonal-free intervals. Or it can be other contraceptive, but trying to make it cycle by cycle without hormonal-free intervals, or to make this interval less. You will help with bleedings and you will help a person with asthma attacks.
Thank you so much. Okay, we have finished our question and we are approaching to our to the end of that session. Then I would like to ask, we will, I think, first start with Natalia and then with Tommaso. Each one of you have covered one part. You have made a beautiful introduction and each one of you have selected some topic. I would like to receive, Natalia, from you related to the problem of adverse uterine bleeding, which is so big clinical important, your reflection as a clinician and also as a woman, what should be your suggestion for the doctors facing the problem of the adverse uterine bleeding? And later on, I will have a question for you, Tommaso.
Oh, Andrea, you are not only the best professional and also a philosopher, because you have asked so important and deep question. My main reflection, of course, is to not to forget this problem at all, to make this problem of bleedings really actively recognized by us, women's doctors. Because as Professor Simoncini had already mentioned, and it reached deeply in my heart, that some of the patients, they don't realize even that they have bleedings. Some patients, due to their cultural specialities, for example, they don't understand that it is a medical problem because it causes anemia, it causes chronic inflammation, and so on, and it decreases the quality of life. So my main idea as a woman, as a women's doctor, is firstly to actively detect abnormal uterine bleedings in our patients. And then, of course, follow the known program for classification, for treatment choices, and so on. But the main is to always remember the problem and to be the first one to ask these 4 important questions to our patients and to detect this problem and to be very empathic to our patients, to describe that it is really a problem, that it is really something which she could improve by herself, and she will get much better results in her social life, in her normal daily activities.
Thank you very much, Natalia. And then for you, Tommaso, you know, the problem of adverse uterine bleeding sometimes lead to the very severe situation. I remind the adolescent menorrhagia as one of the most severe situations that we were facing, because normally when they come to the urgency services, they have already a very, very great anemic situation. And also the total mass of blood that they have is slightly lower than what have an adult woman. Then what is your strategy and how you want to not only to face this kind of situation, but what you want to speak with the doctors to ask about that one? one day are facing a very young patient where the examination and where also the clinical approach is so difficult by the age of the patient.
Yeah, it's a big problem. It's a big problem also because it's sometimes it's frustrating. Yeah, I think we've all experienced that. So we try things that we expect to be successful in adult women, and they don't work. And there's continuous bleeding, and there's of course all the worry about the parents, and so it's also a situation, a family situation, which provides more pressure. And on the other side, we do know that most of these bleedings, once, of course, we have excluded the most relevant problems, we should not forget that some very young women might start bleeding a lot because they have hematologic disorders. This is an age where these things can happen. Sometimes a leukemia is diagnosed because of the incidence of abnormal uterine bleeding with excessive uterine bleeding. So, of course, given for granted that we have excluded everything that is more serious, we also know that these problems are going to go away with time. So, I think that it's really a matter of building up a relationship with the family and with the young woman, trying to give her hope that even if our treatments sometimes are not as effective or completely effective, things will solve out in the near future. We don't need necessarily to use very heavy drugs like GnRH analogs, blocking puberty development because there's an excessive bleeding. We can try to modulate the bleeding, and that's like damage control strategy, I would say. But you know, we need to be good into explaining what is happening, and that things will go okay, you know, with over time. So, but you know, in most cases, if one uses the strategies that we have available, things will go okay completely.
Thank you, thank you, thank you. Then Natalia, Tommaso, my dear friends, thank you very much for being with us today, to have touched this so important, clinically important problem, but also important for the daily quality of life of our women from any age. I think take care of adverse uterine bleeding with proper treatment was a fantastic talk. And then, dear friends, for the next time, I'll invite again to be with us the 6th of December at 3 o'clock, Euro Central European Time, where we will have two masters of the heart and femininity relationship, cardiovascular risk in postmenopausal women, assessment and prevention. And the two are Professor Peter Collins, cardiologist, and Professor John Stevenson, gynecologist, and Professor F, general practitioner and internal medicine, Professor too. And then I would like to remind to all of you to join us in Florence, 8-11 of May 2024, where adverse uterine bleeding will be discussed, and then we will have the pleasure and the enjoyment to see directly to meet Professor Natalia Pedachenko and Professor Tommaso Simoncini, also in Florence. Join with us at the beautiful World Congress of Gynecological Endocrinology in May. Thank you very much, Natalia. All my best regards to Tatiana, to all our Ukrainian friends. I would like to thank again Abbott for the strong support to organize this meeting, and thank you, Tommaso, for being with us and making so beautiful and so attractive all our presentation. Dear friends, thank you. Enjoy your life. Take care of you, and see you soon. See you soon. Goodbye. Goodbye.
Bye-bye.
Thank you. Bye.